I'm Caroline Richardson. I'm a family physician and a health services researcher. Most of my research is focused on physical activity, type 2 diabetes, obesity, and weight loss, and diabetes prevention. I am currently the chair of family medicine at the Warren Alpert Medical School at Brown University. And I am also the editor of Annals of Family Medicine, which is our discipline's primary research journal. I've worked with a lot of really great family doctors and trainees, and I think probably the thing that gives me the most pleasure is all of the mentees that I've mentored in research through various programs and through the National Clinical Scholars Program and through K-Grants mentoring and other mentoring opportunities. I would say some of my recent papers looking at CGM and low-carb diets, in particular, I recently published a randomized controlled trial in a primary care clinic where we took all the patients with type 2 diabetes and randomized them into two groups. One group was invited to try using a continuous glucose monitor to help them learn how to eat a lower carb diet. And the other arm got usual care. And we saw really significant improvements in health outcomes, as well as some decrease in medication use over time. The whole focus of diabetes care was to slow down the progression to the requirement to use insulin injections. The idea being that insulin was sort of the ultimate treatment for diabetes, type 1 or type 2, but that with type 2, you could slow down the progression to needing insulin. And patients really don't like to use insulin because it's needles and it's very intensive therapy that's hard to do. And if you could give people a few extra years where they didn't have to use insulin, that was a win. I think what we've learned more recently is that there are better ways to treat type 2 diabetes than with insulin. Not so much for type 1 diabetes. You need the insulin when you have type 1 diabetes. But with type 2 diabetes, often people have too much insulin. And adding exogenous insulin to that mix is not necessarily the best treatment. It does solve problems. We've developed these two new very exciting classes of medication, SGLT2 inhibitors and GLP-1 receptor agonists, that have really changed the way we think about managing diabetes entirely. Newer CGMs are much less expensive and much easier to use and much more accurate and reliable. And they're really game changers. You know, being the editor of the Annals of Family Medicine, first of all, it's not just about diabetes, which is what my research expertise is in. It's about everything that family doctors have to deal with. Part of our job as a journal is to be the voice of scholarship in family medicine. To push some of the edge of, what family medicine could be, and to continue to advance our discipline. It's rare that a single research manuscript, original research paper, answers all the questions that we might have about a particular condition or treatment plan. And so there are synthesis articles that are published in the American Family Physician that really bring together information from lots of different published original research articles. American Family Physician helps to synthesize and package those in a way that allows practicing physicians to really realize the benefits of having that knowledge that was generated in the original research. Family doctors have the opportunity to really make a big difference in the lives of their patients who have diabetes. Sometimes we miss that opportunity because either of lack of training or lack of resources or lack of access to the critical medications or the CGM. And I think one of my missions, and I started working on this with the Michigan Collaborative for Type 2 Diabetes, but I'm continuing to work on it here in Rhode Island with our diabetology fellowship, where we give family doctors an extra year of training in diabetes care. I would like to have somebody who has real expertise in managing type 2 diabetes in particular in every residency program for family medicine around the country, so that our residents are trained to really be competent and and fairly aggressive about helping patients who have type 2 diabetes get their diabetes under control, prevent complications, and also relieve some of the burden of diabetes and diabetes poor health outcomes on our patient population.